Hello, we are going to be talking about IV therapy, piggybacks, pumps, and more. IV therapy is used to maintain or prevent fluid and electrolyte imbalances. Follow the 6 rights of medication administration and 3 checks with IV therapy. This includes knowing the correct solution, equipment, how to initiate infusions, regulate the rate, maintain the system, monitor for complications, and also discontinue the infusion. We're going to look at IV administration. It is administered into the circulatory system. Large volume infusions can range from 250 milliliters to 1,000 milliliters. Bolus injection is considered an IV push. And volume-controlled infusion examples are a piggyback, volume control set, which you see on the top right-hand corner, and the mini infusion. The volume control set provides small volume of fluid and it dilutes IV medication and reduces risk of too rapid infusion. And with the bottom one, the mini infusion, it pumps small volumes given over a specific time. And this is covered in your Potter and Perry textbook on page 637. IV solutions have come in 3 main categories. Isotonic is most like blood. It's used to expand blood volume. It's the same concentration of solutes as blood. You do need to assess for signs of hypervolemia, such as bounding pulse and shortness of breath. An example of isotonic solution is normal saline and also lactated ringer. Hypotonic solutions provide free water and treat cellular dehydration. Promote elimination via the kidneys. It is less concentrated of solutes than blood. An example of this would be 0.45% sodium chloride. And finally, hypertonic solution has a concentration greater than blood. This draws fluid into the vascular compartment, and it's not for clients with kidney or heart problems. An example of this is D5NS. There is a formula for IV flow rate using the drops per minute. The example that I'm showing you is there is an MD order for an IV to be infused at 125 milliliters an hour with a drop factor of 15. So you would multiply the 125 times that drop factor and divide it by minutes to obtain the drops per minute rate. Most IV solution sets deliver 10 drops per milliliters or 60 drops per milliliter, which is a micro drop. Before hanging an IV solution, it's important to assess what you're giving. It should be clear. If it is cloudy, it can indicate contamination. When documenting an IV start, you're going to document the number of attempts, the type of fluid, if it's a saline lock, insertion site, type and size of catheter or needle used, the flow rate, if the IV is continuously going, the patient's response to the IV, and patency of the system. You should be assessing it every 1 to 2 hours. We're now going to look at the procedure for hanging IV fluids. You're going to remove the IV bag from the protective outer wrapper cover. You should check the expiration date and assess for cloudiness or leaks. Hang the IV bag on a pole. Remove the IV tubing from its bag. Close the roller clamp. Spike the bag. Fill the drip chamber half full by squeezing it gently. Open the roller clamp and prime the tubing. You should fill the entire tubing with IV solution, avoiding any air bubbles. Small air bubbles less than 0.5 milliliters usually are not harmful unless infusing into a central line. Label the tubing with times for solution to be infused, especially if no pump. And with the tubing change date, this is typically every 72 hours. and then adjust the roller clamp to the appropriate drip rate. With hanging IV piggybacks, you're going to open the tubing the same as the IV, close the roller clamp, hang the piggyback on a pole, spike the bag the same as you did the IV, prime the tubing, connect the IV piggyback tubing to the IV tubing, and then place the wire hanger on a pole. You'll then lower the primary bag onto the hanger, set the correct drip rate, and label the tubing with date to be changed. If using an IV pump, set secondary volume and rate. Primary IV will start to run when IV piggyback is infused. Label the tubing with date to be changed. It is important to prevent an IV site infection. It's essential that you wash your hands, use sterile technique, change the solution every 24 hours, change the IV site every 48 to 72 hours, change IV tubing every 48 hours. Use gloves and sharp containers appropriately, and follow your agency policy. Patient education should consist of signs and symptoms of infection or problems, when to call for help, how to prevent the IV from clotting or being pulled out, and this includes arm positioning if appropriate, and how to handle the IV when walking to prevent complications. Nurses are responsible for the IV flow rate maintenance. It can result in fluid overload leading to cardiovascular, renal, or neurologic impairment. It's essential that you therefore assess your patient continuously who has an IV. The flow rate is controlled by the roller clamp or the IV pump and can be affected by patient's position. If it is a gravity IV, it needs to be 36 inches above the site to infuse. If you have an IV that is running by gravity, the rate is controlled by the roller clamp. To determine the hourly rate, you'll need to determine the drops per minute rate. And you do this by, set the rate by counting drips per 15 seconds and multiplying it by 4 to get drops per minute. Readjust the rate as needed. IV pumps deliver IV fluid by exerting positive pressure on fluid tubing. Most pump alarms with an occlusion, but they can continue to infuse even when there's an infiltration. Infusion pumps are good for low hourly rates, patients at risk for volume overload, patients who have impaired renal clearance, and for monitoring IV and medications that need a specific hourly volume. If the patient has a saline lock where they do not have a continuously active IV bag hanging, but they just have the saline lock present, it does need to be flushed to maintain patency. In this general area, saline is used as a standard. Do use a push-pull technique. Potter and Perry reviews this on page 634. It's also important that when patients shower, you need to cover the IV site with plastic. Complications that can occur at the IV site include infection, assess for redness, warmth, swelling, infiltration, assess for redness, edema at the site, burning pain, and coldness. And remember that a backflow of blood does not always mean an IV is not infiltrated. The scale here shows an infiltration scale, and with this I want you to understand that these complications are rated on a scale to help identify the severity with a grading of 0 to 4. Other IV complications include allergic reaction, circulatory overload, and air embolism. Small amounts of air do not produce symptoms because air is removed from circulation. but large boluses of air can cause acute right ventricular outflow obstruction and result in cardiogenic shock and circulatory arrest. Symptoms which develop immediately following embolization are similar to pulmonary thromboembolism. Severity of symptoms related to degree of air entry and include the following: dyspnea, chest pain, tachycardia, hypotension, circulatory shock or sudden death. Nursing actions in this emergent event is to immediately stop the infusion and clamp the line. Do not withdraw the catheter at this time unless it cannot be clamped. Promptly place the client in Trendelenburg position and rotate toward the left lateral position. Administer 100% oxygen and intubate for signs of significant respiratory distress. With intermittent IV therapy, again, remember to flush with normal saline every shift. Use push-pull technique to flush. If you have a needleless system, you need to clamp the tubing while still pushing fluid, usually using 2 to 3 cc's of normal saline to flush. When providing boluses, IV boluses, especially with medications, would be an example. We use the technique called SAS, saline additive saline. So you would give saline through the IV line, then administer the medication, which would be that additive, and then clear the line again with saline. It is important to know how quickly you can give an IV push so that you do not promote medication toxicity. Patient-controlled analgesic, here's a picture. Dosing limits are set by the doctor. Remember to tell the family not to punch the button when the patient's asleep. There are lockouts to prevent overdosing. For security, it has a dedicated line, no extra ports, and 2 nurses need to check and set it up. It is essential that you assess the respiratory rate, level of sedation, pain level, bowel movements, and urinary output. With IV therapy, there are some specific precautions I want to remind you of. Never give potassium chloride by IV push. This can be fatal. Veins cannot be used in patients with a mastectomy, axillary lymph node dissection, lymphedema, paralysis of upper extremities, or dialysis graft or fistulas. In Skills Lab, we're going to have multiple stations for you to look up medications, work with pumps, and calculate IV drip rates. I look forward to seeing you then.